Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling adrenal crisis. So as always, let's kick it off with our practice question to get those brains working. We will circle back to the right answer at the end. A nurse in the emergency department is assessing a client with a history of primary adrenal insufficiency, and they report increasing weakness, fatigue, nausea, and abdominal discomfort after a recent illness. The client is hypotensive and tachycardic. Which of the following additional findings would most strongly support the nurse's suspicion of an acute adrenal crisis? We have A, a serum sodium of 122 and potassium of 6.3. B, a serum sodium of 150 and a potassium of 3.0. C, a blood glucose of 268 and a serum bicarb of 34. Or lastly, D, an elevated serum cortisol level following administration of ACTH. Okay, think it through. Tuck away what you think the right answer might be. We will circle back to that at the end and talk through it. But first, let's dive into an adrenal crisis. Actually, let's back it up. Before we even talk about what an adrenal crisis is, we need to understand the adrenal glands and what the heck our adrenal glands are just doing on a normal day. First of all, where are they? Picture your adrenal glands as two little hats that are just sitting on top of your kidneys, okay? And each of those adrenal glands has two main parts. We have the medulla, or the center, and then the cortex, which is the outside part. So let's talk about the medulla first. The adrenal medulla is your fight or flight. It pumps out epinephrine and norepinephrine, those catecholamines, when you are scared or stressed. On the outside, the adrenal cortex is more like the slow and steady manager that keeps your body stable hour after hour. The cortex actually has 3 layers. I'm not going to get too nitty-gritty here, but overall, the cortex is making aldosterone, your salt and water hormone, your cortisol, that stress hormone, and then also a small amount of androgens. We're definitely going to talk about aldosterone and cortisol. Those are going to be a big focus here. Cortisol is almost like the body's head coach during stress. Under normal conditions, the hypothalamus is going to release something called CRH, which just tells the pituitary, hey, you need to release ACTH, which then tells the adrenal cortex to release cortisol. I always think of it as like a domino effect where the hypothalamus is in charge. It's the maestro. It's like, whoa, we're stressed. We need cortisol. So it releases that CRH, cortisol releasing hormone. It travels over to the pituitary to say, release ACTH. And then that finally gets down to the adrenals and causes them to release cortisol. So like dominoes, boop, 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 boop. And that whole domino effect situation is the HPA axis: hypothalamus, pituitary, and then adrenal. We start with the maestro of the hypothalamus and make our way down to the adrenal. And ultimately, end of the day, end of the domino cascade, when cortisol comes out, it kind of does a little bit of everything. It maintains the blood pressure by keeping your blood vessels more responsive to those catecholamines, epi and norepi. So when they say, tighten up, vasoconstrict, they'll actually be able to listen. What else does it do? Cortisol helps with your blood glucose by stabilizing and promoting gluconeogenesis in the liver, and that prevents you from crashing when you haven't eaten. It also stabilizes cell membranes and modulates the immune response so inflammation doesn't just run wild, okay? So cortisol is our head coach of stress. More cortisol, more stress. And what happens when all of a sudden that cortisol just disappears? Okay, think about all the things we just said. Cortisol was tightening up our blood vessels. So we lose that cortisol, the blood vessels lose that responsiveness. Even though we're pouring out the epi, the norepi, our vessels are a little floppier. Our vascular tone, not so great. Blood pressure is gonna go down. Okay, we just talked about cortisol helping with gluconeogenesis, so we're keeping our sugars up. If that cortisol is not there, the liver is less able to keep glucose levels stable during stress. So we can get hypoglycemic. And then we said it was also helping stabilize the cell membranes, the immune system, and whatnot. And without that balancing effect, everything gets a little chaotic. The cells get a little leaky, that membrane. The immune system, the inflammation can kind of get out of whack because our cortisol has just left mid game. Our head coach has exited, and all those systems it was keeping up with kind of start to crash. Okay. Now, that's just cortisol. I mentioned another key player that adrenal cortex is making for us. You remember what it was? Think back, our water hormone, aldosterone. Okay, adrenal cortex, we're thinking cortisol and aldosterone. Cortisol, stress, aldosterone, water. Basically, aldosterone works on the kidney tubule. Its job is pretty simple. It goes and tells the kidney to just hold on to sodium and water and go on and get rid of potassium. We let the sodium in, water follows sodium. So we keep up our circulating volume with that water and that sodium, and we pump out the extra potassium. So if that aldosterone disappears, then we stop retaining that sodium and water. We stop excreting that potassium. Potassium's going to go up, but fluid volume and sodium are going to go down. So we end up worried about hyponatremia, hypovolemia, that volume depletion, and in exchange, way too much potassium, that hyperkalemia. Okay, so why did I spend so much time telling you about the things cortisol and aldosterone does, those things that the adrenal cortex makes? Well, in an adrenal crisis, the adrenals are not making the things they need to. So that cortisol is gone, that aldosterone is gone. And that's when we're going to see all the effects we just walked through. Okay, how does that happen though? We have something called Addison's disease. In chronic Addison's disease, the adrenal cortex is gradually destroyed, usually by autoimmune damage. Maybe we have infection or infiltrative disease, and over time, that adrenal cortex is eroded. So cortisol and aldosterone start to fall. Now, naturally, the body's going to try and compensate. Of course, it's very smart, it's wanting to stay alive. So the pituitary will pump out more of that ACTH we mentioned, where it was that domino effect on the HPA axis. And we were like, hey, we need some more of that cortisol. It's trying to squeeze more cortisol out, but they can only do so much because of that damage to the adrenal cortex. Now, one, I think, like, very interesting little tidbit, I'm just going to go off to the side here, is that because we're making more of this ACTH to try and stimulate that cortisol, the ACTH and related peptides can actually stimulate melanocytes, those cells in our epidermis that make melanin, which is why when we have chronic Addison's disease, they might have a presentation with very bronzed or tan looking skin, even if they're not in the sun. That ACTH is stimulating melanocytes. They're making more melanin as like a side effect of their bodies trying to compensate and get them to make more cortisol. That feels like so random to me, but for some reason, understanding that, it was just a cool nugget that like stuck with me and helped me remember that key finding of Addison's disease. They have that bronzed tan skin. Okay, so that's kind of the chronic situation going on, but this episode's about adrenal crisis. So, what do we mean when we say getting into crisis? That is like the crash where the body really starts to run out of the cortisol and the aldosterone on board. A client with Addison's is probably relying on what we call exogenous steroids. So, like, we're just giving them that steroid medication to kind of keep things up. But let's say they stop taking that, or a major stressor hits, like infection, trauma, surgery, whatever. Well, when the body's under stress, it needs more of that cortisol to mount a stress response. And a client with Addison's, where that adrenal cortex has been destroyed, simply cannot do that. So when there's not enough of that cortisol, when there's not enough of that aldosterone, we crash. That is the adrenal crisis. Here's what's happening. We don't have enough cortisol to maintain vascular tone, hypotension. We can't maintain that blood glucose, hypoglycemia. We can't maintain enough aldosterone to hold on to sodium and water and get rid of potassium. So our blood volume drops, hypovolemia. Our sodium drops, our potassium skyrockets, hyperkalemia. Like literally at the cellular level, everything is falling apart because we don't have the hormones we need to mount that stress response. Okay, so I think that's a good point for us to segue into a case study for today to look at how that plays out and what on earth we're going to do about it. So, you are going to be on a med surge floor today. The ED is calling a report up to you on a 45-year-old woman with a history of Addison's disease. She had been diagnosed a few years earlier. She is on both hydrocortisone and fludrocortisone at home. Think about why that is. Her adrenal cortex not making enough of those steroids. So we are giving them exogenously. She is dependent on taking that hydrocor and that fludrocortisone to keep her body sustained and have enough of those hormones. Now, over the last 2 days, this client had what she thought was just a stomach bug. And she toughed it out, she didn't want to come in for just a stomach bug. But within the past 2 days, she has become really weak, really dizzy, not herself, super fatigued, and ultimately her partner brought her in to the emergency department. So they call this whole report up to you, roll her on to the unit. Let's go and get your assessment. Okay, looking at her from across the room, pale, a bronze tint to her skin. That's going to kind of, you already know she has Addison's disease, so you're seeing that chronic finding. But more so concerning is her demeanor. She's still, her eyes are half closed. She's delayed in her responses, really struggling to try and answer questions. Let's get her vital signs. BP, 80s over 40s. Heart rate, 120s. Respiratory in the low 20s. She's satting fine on room air, but when you go and do her physical assessment, when you go and touch her to palpate, her extremities are cool, her cap refill is delayed, and when you try to sit her up, she is so faint and dizzy, she thinks she is going to pass out. Okay, so think through the physiology of that assessment we just talked about. She has really low blood pressure and she is tachycardic. I am personally uncomfortable with this client being on a med surg floor right now because 80s over 40s is scary. That is telling me that her blood circulating volume has majorly dropped. That aldosterone, she doesn't have enough of it. She's not holding on to water. Hypovolemia is causing hypotension. And then why is her heart rate up? Because her body's trying to compensate for that low circulating volume. Additionally, remember, she doesn't have enough cortisol going on, so her blood vessels are not tightening up effectively in response to the catecholamines, epi and norepi. So double whammy there with that really low BP. I am personally, if I am this med surg nurse, starting to advocate for transfer to the ICU, calling a rapid, because I just don't love how this looks, especially with her mental state. We did get some labs down in the ED, so let's kind of look at those results first. Serum sodium 121 and potassium 6.4. Let's talk about those first. Yes, you're going to get normal ranges on your NCLEX. Okay, I'll get that out of the way first. But I still want you to be able to interpret what a low or high value means. Sodium of 121 is low because we don't have enough aldosterone. We're not hanging on to it. Hyponatremia is going to put us at risk for neuro problems. Biggest thing is seizure. Serum sodium of 121, I'm at risk for seizures. Now we saw that potassium of 6.4. That is high hyperkalemia. I'm worried about arrhythmias, tall peaked T waves that can eventually turn into fatal rhythms if I don't treat. So I got to get this lady up on a cardiac monitor pronto. Okay, other labs, those are my electrolytes I'm worried about. Blood glucose is coming back at 58. So we're hypoglycemic because we don't have that cortisol. That's not helping with the gluconeogenesis. I'm not able to mount that stress response and keep my sugars up. Okay, sugar, sodium, potassium, those are the three key things I am looking at. Your provider's probably going to grab some other labs too, especially if they come in through the ED. But that is what I want on your radar for adrenal crisis. So, with all that information, what do we need to do? Like I said, if I'm the med-surg nurse, I'm going to go ahead and call a rapid because this looks like shock to me. She's hypotensive, she's tachycardic, her lights are way out of whack. We need more intensive monitoring. We are going ABC priorities. Airway, make sure that is patent, keep that oxygen on because perfusion is not looking great. I'm going to go ahead and get 2 large bore IVs because I'm going to need labs and we're going to have to replace some volume. We're going to be checking that blood sugar frequently at the bedside. Like I said, for sure going on a cardiac monitor because of that potassium level and checking vitals very frequently. First thing we're going to start addressing is that hypotension due to volume depletion. We are going to give an isotonic fluid that goes in the vessel, stays in the vessel, and really expands that intravascular volume to restore her blood pressure. Now we're going to address that low glucose by adding in some dextrose to that fluid so we can get that blood sugar up without dropping her sodium farther. And then we're going to give her some steroids. She needs IV hydrocortisone. This is really addressing the root issue here. Like, we can pour fluids into this lady all day, but until her body has enough of those steroids so that her vascular tone goes up and her vessels can respond, we're still gonna be hypotensive. So IV hydrocortisone, we would call it a stress dose, is absolutely necessary. We need to prioritize getting that in there quickly. Hydrocort acts as both a glucocorticoid and it has some of that mineralocorticoid activity from the aldosterone. So it's doing a couple things for us with helping restore that vascular tone to get the BP up and also correcting that cortisol deficit. So if there's one thing you remember, I'll say it one more time. We're in adrenal crisis. We need a stress dose of IV hydrocortisone. All right, we're replacing the steroid, we're replacing the volume, getting that blood pressure up. The other major priority I hope you're thinking about is that potassium level. We have got to address that hyperkalemia before it turns into a lethal arrhythmia. So, what do you do for high potassium? You guys remember? We're going to give some IV calcium to stabilize the cardiac membrane. That is not going to fix the hyperkalemia, but it is going to prevent, hopefully reduce the risk of those lethal arrhythmias by stabilizing the cardiac membrane. After that, we're going to give insulin with dextrose. That insulin is going to open up our cells and the sugar is going to go inside and bring the potassium with it. Remember, potassium should be living inside the cells, so we're going to scooch it back in there. Then a little bit later, we can give some other meds to help get potassium out of the body. Those just take a little longer. Those are things like Kayexalate, which is going to help eliminate from the intestines. And then the other one you might see is continuous albuterol. Albuterol via a nebulizer. I was so confused the first time I saw that, but albuterol is another one that can help get that potassium down. The quickest, and what we're going to do in this case with that really high K level though, is the IV dextrose with insulin. We're going to shift that K intracellularly, get all of this under control, keep her on that cardiac monitor, and then we can do other interventions later as well. So those are your big 3 that I want you thinking about. I want you thinking about getting that blood pressure up. We're giving that volume. I want you thinking about getting that potassium down with our IV dextrose and insulin. I want you thinking about getting that blood glucose up with that IV dextrose. And then the underlying picture, getting that steroid that the body is really missing into the body with your IV hydrocortisone. Okay, those are the big things you're addressing. Again, really close, consistent monitoring. This is definitely an ICU client while the body stabilizes and gets back to baseline with the appropriate amount of steroids. So that being said, I think it's the perfect place to bring us back to our practice question. Let's see now if you can get to the right answer and understand why. So again, you're in the ED. You've got a client with a history of primary adrenal insufficiency that reports increasing weakness, fatigue, nausea, and abdominal discomfort after a recent illness. The client is hypotensive and tachycardic. Which of the following additional findings would most strongly support your suspicion of an acute adrenal crisis? We had a serum sodium of 122 with potassium at 6.3. B, a serum sodium of 150 with potassium at 3.0. C, a blood glucose of 268 and a bicarb of 34. Or D, an elevated serum cortisol level following administration of ACTH. Think it through. This is the picture of the case study we just walked through. So think about the client you just helped. What is the picture of adrenal crisis? It's A, right? That low sodium and high potassium, which comes because of our lack of aldosterone. We can't hold on to that sodium, so it goes down. And instead of excreting potassium, we're hanging on to it. So we become hyperkalemic. And B, we had that flip-flopped. So we had a high sodium with low potassium, not what we would see. In C, we saw a high glucose when in fact we know the absence of cortisol is going to drive our blood glucose down. Hypoglycemia, hyponatremia, and hyperkalemia is kind of the trifecta of labs we're looking at in adrenal crisis. And lastly, I'm sure you crossed out D right away when you saw that elevated serum cortisol, because we know the driving factor of this adrenal crisis is the fact that we don't have enough cortisol. If there's one thing you remember, I want that to be your key takeaway for the episode. In adrenal crisis, we have a failure of our body's stress system. We lose our cortisol, we lose our aldosterone. So low cortisol means we can't increase that blood pressure. We're going to become hypotensive. Low aldosterone, we're going to lose sodium, lose water. We're going to hang on to potassium and become hyperkalemic. Our nursing priorities are to rapidly recognize this, replace that volume quickly to get the blood pressure up, get the sodium and get the sugar up, and most importantly, give that high dose IV steroid, that hydrocortisone, to replace the missing cortisol. If there's one thing to remember, it's adrenal crisis means not enough steroids, and we got to give them some steroids. That IV hydrocort is paramount. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.